Rachel. I am from the University of KwaZulu-Natal in South Africa, and today I'm going to be presenting my research study, and the title is On the Knowledge and Practices of Healthcare Professionals in South Africa, on ototoxic hearing loss in children receiving platinum chemotherapeutic drugs. Okay, so the agenda today. So my presentation will cover the introduction, the methodology, the results, the discussion, and conclusion. So globally, cancer cases are expected to rise by 70% in the next 2 decades. Although childhood cancer survival rates reached about 80% in developed countries due to treatments like chemotherapy and radiotherapy, survival in many African regions remain about 30% due to limited access to screening and specialized care. So in South Africa, specialized oncology services exist within tertiary hospitals, but fewer than half of suspected childhood cancer cases are diagnosed, and many are identified at advanced stages. As a result, platinum-based chemotherapeutic drugs are required. So platinum-based chemotherapeutic drugs like your cisplatin, your carboplatin, and your oxaliplatin are widely used either individually or with other treatments to manage many malignant tumors. However, their effectiveness is accompanying a wider range of toxic side effects. These include your nephrotoxicity, your neurotoxicity, cardiotoxicity, gastrointestinal complications, and ototoxicity. Platinum-based ototoxicity typically presents as permanent bilateral high-frequency sensorineural hearing loss and tinnitus or tinnitus. Damage to hearing above 2000 Hz often impairs speech discrimination. Additional symptoms can include your hyperacusis, oral fullness, and vertigo or dizziness. So patients may view ototoxicity-related hearing loss as a major obstacle to daily functioning and overall quality of life, despite the significant benefits of cancer treatments. In children, even a mild hearing loss can interfere with the acquisition of speech-language skills. More severe high-frequency losses can disrupt speech perception and production, language development, intelligibility, and overall communication. So early hearing loss can slow language acquisition. So managing platinum-based ototoxicity requires a coordinated, So it requires a coordinated multidisciplinary effort involving audiology, oncology, physiotherapy, pharmacy, otolaryngology, nursing, occupational therapy, pediatrics, and psychology. So in children, ototoxicity management often differs from adult care, which can lead to miss or delayed detection and worsen the challenges associated with hearing loss. So Stratford et al. Found that children with ototoxic hearing loss experience low quality of life, particularly in aspects of communication, interdependence, and emotional well-being. However, with appropriate intervention, the severity of ototoxicity and its impact can be mitigated. With healthcare professionals treating children on platinum-based chemotherapy lack adequate knowledge and training, recognizing adverse drug reactions, the resulting consequences can be severe and irreversible. So the methodology of my study, the aims and objectives, which are to describe the perception and practices of healthcare professionals on ototoxic hearing loss in children receiving platinum-based chemotherapy. So that was the aim. And the are the objectives. To describe healthcare professionals' awareness of ototoxicity and the ototoxic effects of platinum-based drugs on the auditory system. To describe the practices of healthcare professionals in the ototoxic monitoring program for children. To describe the healthcare professionals' perception, the role of audiologists and that of other team members in the ototoxicity monitoring program for children. And lastly, to identify factors influencing the practice of healthcare professionals in an ototoxicity monitoring program for children. So the study design was a descriptive survey design was employed in the study, and the study was conducted at 2 public hospitals offering oncology services in KwaZulu-Natal, South Africa. The study population included ENTs, pediatricians, pediatric oncologists, audiologists, registered nurses, pharmacists, clinical psychologists, and physiotherapists. A total of 90 participants were needed to meet the requirement of a 95% confidence level, a 5% margin of error, and a 5% significance level. In this study, 74 healthcare professionals participated, resulting in an 82% response rate. So the data was collected using an anonymous self-administered questionnaire containing primarily closed-ended questions with a few open-ended items. The instrument included roughly 31 questions, which were divided into 5 sections. So the results which were obtained will be separated according to each objective. So objective 1, this graph reflects participants' knowledge of the symptoms associated with ototoxicity. 49 participants identified hearing loss, while 39 indicated tinnitus, and 19 indicated hyperacusis as a symptom of ototoxicity. This bar graph reflects participants' knowledge on the side effects of platinum-based chemotherapeutic drugs. And 45 participants recognized ototoxicity as a potential side effect of platinum-based chemotherapeutic drugs. However, only 8 and 25 participants indicated oral fullness and tinnitus, respectively, as side effects of platinum-based chemotherapy drugs. This graph reflects the participants' understanding of risk factors of ototoxicity caused by platinum-based chemotherapeutic drugs. 43 participants identified the dose, duration, and mode of administration as risk factors. However, it is worth knowing that 20 participants indicated not knowing the risk factors of ototoxic hearing loss as reflected in this figure here, or this graph rather. The next objective, which is objective 2, and this graph reflects the components of the ototoxicity monitoring program. And 20 participants, as seen in the figure, did not accurately identify all the components of an ototoxicity monitoring program. In comparison, only 3 participants knew that treatment adjustment based on changes in hearing was part of the ototoxicity monitoring program. So across professional groups, most participants accurately identified their roles within the program, but there were notable gaps. So all audiologists accurately identified most responsibilities, but one did not include raising awareness of ototoxic drugs, and the other incorrectly listed adjusting treatment regimens as part of their role. Most pharmacists who participated recognized their role in raising awareness about ototoxic medication, but only 7 identified suggesting otoprotective options as within their scope. All clinical psychologists correctly acknowledge their role in supporting patients' psychological well-being, though one did not include providing counseling to family members. Only half of the physiotherapists identified interprofessional vestibular rehabilitation as part of their responsibilities. All pediatricians accurately recognize their roles, including assessing comorbidities, initiating a treatment, inquiring about auditory symptoms, and referring for audiological assessments. Most ENT specialists who participated correctly identified asking about auditory symptoms and referring for audiological assessments, while 63.2% of the nurses recognized their role in monitoring ototoxic symptoms and making referrals. Fewer identified providing informational counseling, and some incorrectly included vestibular rehabilitation. And the pediatric oncologist all correctly identified their key responsibilities, which included assessing comorbidities, initiating treatment, requesting baseline assessment, reviewing treatment in response to ototoxicity, and inquiring about auditory symptoms. This table here reflects the overall knowledge scores on ototoxicity, which was divided into the different components which we assessed or looked into. And the next objective, which is objective 3, all audiologists reported performing ototoxicity, tympanometry, acoustic reflex testing, and pure tone audiometry at baseline and follow-up. However, only half conducted high-frequency audiometry. Most ENT specialists reported referring children for audiological assessment, and nearly all use an interprofessional approach when managing patients. Among nurses, 68.4% indicated making audiology referrals, with difficulty hearing being the most common symptom, while few recognize hypersensitivity to sound as an indicator. 1/3 of the occupational therapists referred patients for audiological assessment and used interprofessional collaboration. 40% of physiotherapists did not assess balance in children on platinum-based chemotherapy. Among clinical psychologists, half reported counseling families or caregivers, and most began counseling when emotional difficulties became evident. 2 psychologists used an interprofessional approach. Pharmacists showed limited involvement in patient education. Only 18.2% reported explaining ototoxic effects to families before treatment, and just 35.3% use interprofessional collaboration. The pediatric oncologist reported referring all children on platinum-based chemotherapy for audiological evaluation. Similarly, both the pediatricians who participated indicated that any child receiving platinum-based chemotherapy should be referred to an ototoxicity monitoring program, and both use an interprofessional approach. So the next few slides will reflect the results for objective 4. So this pie graph reflects the factors influencing the practice of healthcare professionals in managing children who present ototoxicity. So 14 healthcare professionals indicated that a lack of resources influenced their practices in managing ototoxicity in children. Other factors included the availability of a multidisciplinary team, time constraints, and a lack of knowledge of drugs and ototoxicity. The regression analysis conducted indicated that higher levels of knowledge were associated with improved practice performance, implying that knowledge may be an important predictor of practice-related outcomes. So our discussion includes, the current study found that although most participants had been educated in South Africa, more than 1/3 reported receiving no training on the ear, hearing, or ototoxicity. Over half felt that the training they had received were insufficient. These results indicated that many South African trained healthcare professionals felt underprepared to manage patients receiving ototoxic medication. Such feeling of inadequacy may have consequences for both practitioners and patients. Odlin et al. Noted that professional inadequacy can disrupt healthcare workers' sense of identity and alter how they perceive their roles and responsibilities. This gap in competency likely reflects an underlying educational gap and highlights the importance of strengthening academic preparation on platinum-based or platinum-induced ototoxicity before clinicians enter practice. Accordingly, undergraduate audiology programs and in-service training could incorporate more comprehensive content on ototoxicity. The findings indicate that in the absence of adequate undergraduate training in ototoxicity, many healthcare professionals rely on alternative educational avenues. More than half of the participants reported receiving training through in-service programs, postgraduate trainings, workplace orientation, or on-the-job learning. This highlights the role of supplemental training platforms in enhancing clinicians' ability to manage patients undergoing platinum-based chemotherapy. The inadequacy of existing education and training is further reflected in participants' knowledge of ototoxicity risk factors. Over a quarter reported being unsure whether risk factors existed for ototoxic hearing loss in children treated with platinum-based chemotherapy. Overall, participants demonstrated only moderate knowledge of these risk factors, suggesting uncertainty that is consistent with their reports of insufficient training. Given that awareness of risk factors and early symptoms are essential for identifying vulnerable patients and implementing timely management strategies, these gaps may hinder effective ototoxicity prevention and monitoring. In relation to participants' knowledge of symptoms associated with ototoxic hearing loss, 20.3% identified dizziness as a symptom, while just over half recognized tinnitus as an associated indicator. Overall, participants demonstrated only elementary level of knowledge of ototoxicity symptoms. A Cowting-based study reported that although 80% of oncologists had some understanding of chemotherapy-related auditory symptoms, 20% remained unaware of the symptomatology experienced by patients using ototoxic medication. Knowledge of ototoxic symptoms and risk factors are essential for early identification of children at risk for hearing loss, thereby enabling prompt detection and intervention. Early management is particularly critical in pediatric population as acquired hearing loss can negatively affect language development, emotional regulation, social engagement, and broader psychosocial outcomes. In this study, 60% of participants recognized ototoxicity as a side effect of platinum-based chemotherapy, whereas far fewer identified hyperacusis and oral fullness as potential outcomes. This limited awareness is notable given that hyperacusis is a debilitating condition often associated with medication-induced hearing loss. Overall, participants demonstrated only elementary level knowledge of side effects of ototoxicity, indicating a substantial gap in understanding. Comprehensive knowledge on the side effects and risk factors associated with platinum-based chemotherapy is essential for effective patient education during pre-treatment counseling and ongoing care. As such, information supports the early identification of ototoxicity. Importantly, early detection is within a multidisciplinary ototoxicity monitoring program, rather than the sole responsibility of the audiologist. In the study, 92% of participants acknowledged the critical role of audiologists in ototoxicity monitoring. Most respondents correctly identified the responsibilities of audiologists as well as other professionals within the monitoring team. Despite this generally positive outcomes of participants were unsure whether their hospital had an established ototoxicity monitoring program, which may contribute to limited number of referrals observed. This uncertainty underscores the need for strengthened training and education on the structure and implementation of ototoxicity monitoring programs. The study revealed notable gaps in participants' understanding of ototoxicity monitoring protocols. More than a quarter were unaware of the program's components. Overall, participants' knowledge of the program components were classified as not achieved. These findings are concerning given established guidelines. According to the HPCSA, children receiving platinum-based therapy require follow-up assessments at 3, 6, and 12 months post-treatment. Long-term monitoring is essential as delayed onset hearing loss may occur. The cisplatin can remain within the cochlea for up to 2 decades. Adherence to ototoxicity monitoring program is therefore critical for ensuring timely identification and management of hearing loss. Communication difficulties resulting from hearing loss can lead to long-term emotional challenges, including social isolation, loneliness, and depression. Families of children with hearing impaired also experience significant stress, financial strain, and communication difficulties. The current study identified several systemic challenges affecting the implementation of the ototoxicity monitoring program, particularly staff shortages and limited resources. Participants reported that insufficient staffing hindered effective service delivery, consistent with global projections of a 10 million healthcare professional deficit by 2023. In sub-Saharan Africa, human resource constraints are a major weakness, with fewer than 1 healthcare worker per 1,000 people compared to 10 per 1,000 in Europe. In South Africa, inequitable distribution of professionals within private and public sectors, as well as among provinces, exacerbating healthcare challenges. Poor working conditions and understaffing contribute to physical and psychosocial exhaustion among healthcare personnel. In addition, the study highlighted a lack of medical equipment and inadequate access to rehabilitation services, further constrained clinical practice, aligning with prior research demonstrating the negative impact of equipment shortages on patients, staff, and overall health system functionality. Financial limitations, insufficient human resource development, gaps in team members, knowledge of ototoxicity, poor communication among healthcare professionals, and limited training further impede the effective management of ototoxicity. These findings underscore the multifactorial barriers to optimal care in ototoxicity monitoring and the need for systemic interventions to strengthen workforce capacity, resources, and interprofessional collaboration. So the conclusion of the study included the findings of the present study reveal a clear relationship between healthcare professionals' knowledge and their practice in ototoxicity monitoring. This highlights the need to strengthen the knowledge base of professionals involved in pediatric oncology care to improve adherence to best practice. Education and training initiatives at facilities providing pediatric oncology service are essential to enhance healthcare professional competency in this area. Knowledge gaps were identified in several key areas, including recognition of hearing-related symptoms, awareness of the existence and components of the ototoxicity monitoring program, understanding the duration of monitoring, and proper implementation of HPCSA guidelines. Despite these gaps, participants demonstrated awareness of the critical role of audiologists within the monitoring program. However, small sample sizes within the professional groups limited the generalizability of findings, and the reliance on self-reported questionnaire data may have restricted the depth of insight. Further studies could benefit from qualitative methods such as focus groups or interviews to gain richer understanding. Clinically, the study underscores the need to review and enhance undergraduate curricula to include comprehensive training on ototoxicity, to implement regular structured training programs for healthcare professionals, and to ensure that oncology facilities have accessible resources for ototoxicity monitoring. Furthermore, the Department of Health could prioritize equitable distribution of resources, strengthen human resource capacity, and improve access to rehabilitation services. Further research could explore healthcare professionals' knowledge and practices regarding ototoxicity in children receiving platinum-based chemotherapy at a national level and assess the feasibility of implementing the HPCSA guidelines effectively. So these were the references that were used for the presentation. Thank you.
Overview. What is the nasal septal deviation and why is nasal septal deviation clinically important? Role of CT imaging in identifying anatomical variation, clinical impact, symptoms and complication, management, medical and surgical, brief summary of our CT patient finding in Benghazi, and final conclusion. Okay, anatomy of the nasal septum. Nasal septum located in the mid-sagittal plane, separated the left and right nasal cavity, and it is made up of both bone and cartilage. Bony part shown in the photo, perpendicular part, a plate of ethmoid. It has posterior portion and vomer and crest of the maxilla from the inferior and palatine bone. Okay, the nasal septum receives arterial supply from the splenopalatine artery and anterior ethmoidal artery and superior labial artery, which converge in Kesselbach plexus at a common sites of the nose bleeding or epistaxis. Cartilaginous parts is the from anterior and inferior portion. The septum separated the nasal cavity into passage and play role in airflow regulation and humidification and filtration, support of the nasal dorsum. Okay. In the aim, the proposed study is used CT scans to examine the structure difference in the nasal septum among adult Libyan in Benghazi. Object assess the prevalence of nasal septum anatomical variation in Libyan adult. Second, compare nasal septal variation between male and female to identify morphometric difference. Number 3, classify nasal septum deviation and abnormality using CT scan observation. In methodology, study design retrospective study using CT scan of the nasal region from Al Jala Teaching Hospital in Benghazi, sample 300 individual Libyan adult aged 8 years and older with CT scan from January 2025 to January 2026. Excluded criteria, excluded case with skull pathology or fracture, poor image quality, age below 8 years. and using anonymity. Okay, type of septal diffusion. Nasal septal diffusion present in several distant pattern, in 6 pattern. Number one, C-shaped diffusion. Number two, S-shaped diffusion, septal spore, and high diffusion, and low diffusion, posterior diffusion, and last complex or combined variation. CT help in identify direction of deviation and severity, involvement of bony or cartilaginous component. Okay, CT-based anatomical variation, study result, study population total participant 300 Libyan adult, gender disturbance male 65% and female 44%. Key finding most common deviation type C-shaped deviation, most frequent, S-shaped deviation, second most frequent, septal spore commonly association with deviation. Additional finding commonly affected region mid-septal diffusion was the most prevalent, like in this photo. Number one, it has mild diffusion. Uh, when classifying nasal septal diffusion according to angle, uh, we uh, uh, we 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 uh, we we classify the type of the diffusion three type: mild and moderate and severe. Mild from the 5 to the 12, moderate above the 12 to the 50. Above the 50 it has severe, like in the photo it has to the left sides mild, and in below photo it has to the right sides it has moderate. Okay. So, okay, commonly affected region mid-septal diffusion was the most prevalent. Laterally right side diffusion was light, more common than left. Age association, no statistically scientific correlation between diffusion severity and age. Okay, clinical impact of nasal septal diffusion, nasal obstruction, primary symptoms affected airflow, mouth breathing, compensatory breathing pattern, sleep disturbance and snoring, disturbed sleep quality, recurrent sinusitis, impaired sinus drainage, headache and facial pressure, chronic discomfort because it has highly contraction, and lastly, epistaxis or nose bleeding, less common complication reduced quality of due to chronic nasal airflow limitation. Symptoms and complications. Symptoms of nasal septal diffusion: nasal blockage and obstruction, difficulty breathing, especially during exercise because is increase of the contraction, mouth breathing, snoring, hyposemia, reduced smell, persistent nasal dryness. In complication, recurrent sinusitis, frequent headache, sleep disturbance, turbinate hypertrophy, chronic mucosal inflammation, in rare case, septal ulceration or crusting. How to diagnosis of nasal septal diffusion. First one, anterior rhinoscopy, first line examination in clinic, nasal endoscopy identifies poor posterior diffusion, mucosal condition. Number three, CT image, gold standards for evaluation type of diffusion, severity, anatomical variation, and associated sinus disease. Symptoms assessment tool, nose score, and VAS. Medical management. Medical management focus on symptoms relief and association condition. Number one, topical nasal corticosteroid spray, reduced inflammation and improve breathing, not treatment. Saline irrigation, improve mucociliary clearance. Short-term decongestant, use with caution to avoid rebound condition. Antihistamine indicated in allergic patient or in allergic case. Treatment of association condition, address rhinitis or sinusitis. We show important note, medical therapy does not correct the deviation itself, but it reduces inflammation and help the patient breathe better. Indication for surgical management, persistent symptoms despite adequate medical therapy. scientific airway obstruction, recurrent sinusitis associated with deviation, severe anatomical deviation seen on CT scan, deviation interfering with endoscopic sinus surgery. Surgical option, septoplasty, most commonly performed procedure for nasal septal deviation, correct deviation by riptostuning or rasping the septum while preferring structure support, can be combined with turbinant reducent if needed. Number two, submucosal resection SMR, older but still used technique, remove deviated portion of cartilage and bone, useful in severe deviation but carries high risk of septal perfusion compared to modern septoplasty. Number three, endoscopic septoplasty, like in the right photo, minimally invasive approach allowing excellent visualizing of posterior deviation, preferred when deviation is complex or association with sinus pathology, offer reduced bleeding and faster recovery. Number four and last, combined procedure, septoplasty plus turbinate reduction or septoplasty plus functional endoscopic sinus surgery when sinus disease coexists. In conclusion, nasal septal deviation is a common anatomical condition with scientific impact on nasal airflow and overall quality of life. CT image provide accurate identification of deviation type and association anatomical variation, making it essential for surgical planning. In our CT patient study of 300 Libyan adults, the most common deviation were C-shaped, followed by S-shaped and septal spore variation. Mid-septal deviation was the most prevalent pattern, with no scientific correlation between severity and age, proper diagnosis and individual's management, whether medical or surgical, improving patient outcome sufficiently. Nasal septal deviation remain condition where clinical evaluation plus CT finding together guide optimal treatment decision. And this is reference, and thank you for listening. I would be pleased to address any question or engaging in discussion. Thank you.
Thank you, Doctor.
Nedelka, I am a graduate student and an otorhinolaryngologist. I am from Belarus. I bring to your attention the presentation of our report. The primacy of medicinal treatment for chronic rhinosinusitis with nasal polyps, the minimal invasiveness of surgical intervention, and the combination with perioperative drugs preparation are common positions worldwide. One of the most common approaches in the treatment of chronic rhinosinusitis with nasal polyps is functional endoscopic rhinosinus surgery using intranasal glucocorticosteroids. The efficacy of drug therapy is as high as 50%. Possible complication of surgical treatment and the recurrent nature of the disease require the search for new therapies for chronic rhinosinusitis with nasal polyps. Reducing mucosal remodeling, controlling mucosal inflammation, and repairing the mucosal barrier are essential for the elevation for chronic rhinosinusitis with nasal polyps. And the use of mesenchymal stem cells with immunomodulatory properties may be a new therapeutic option. From cell therapy view, pathogenesis of chronic rhinosinusitis with nasal polyps is based on abnormal remodeling response and immunoregulatory disbalance with a decrease in regulatory T lymphocytes and disruption of the migration potential. Mesenchymal stem cells of olfactory line have multiple differentiation potential, have low immunogenicity, doesn't have increased risk of malignant cell transformation. They have immunomodulatory function due to migration and implantation in the inflammatory mucosa of the nose, restoring the immune balance of T helper 1, T helper 2, and activating T regulatory cells, able to stimulate tissue regeneration. Mesenchymal stem cells can eliminate the inflammation, weaken the embolised response of T helpers, and improve healing process by increasing quantity and quality of extracellular matrix. Mesenchymal stem cells exert their influence through intercellular contacts and the release of solute factors. The objective of our study is to assess the effectiveness of biomedical cells product based on mesenchymal stem cells olfactory line in the treatment of patients with chronic rhinosinusitis with nasal polyps. The study was based on data from patients aged 24-74 who had undergone treatment in a Republican Scientific and Practical Center of Otorhinolaryngology. The main group 1 includes patients who underwent cell therapy after surgery. The main group 2 includes patients who had cell therapy during the perioperative period. The control group includes patients who haven't undergone cellular therapy. You can read exclusion criteria on this slide. Inclusion criteria are right and informed consent, female and male age from 18 from 85 years, codes of disease in the International Classification of Disease are G33.0, 0.1, 0.8, 0.9. All patients underwent the algorithm of diagnostic procedures upon admission to the hospital before surgery and up to 6 months after surgery. Analysis of patient complaints, surgical history, endoscopic examination of the nasal cavity, rhinocytogram. Surgical treatment included surgery on the paranasal sinus and nasal cavity. Histological assessment of the nasal mucosa was performed at 8 patients of the main groups and 6 patients of the control group, up to 3 months after cell therapy and after surgery in the control group. All patients used intranasal glucocorticosteroid for 2 months after surgery at a dose of 400% micrograms per day. There is no statistically significant difference between the groups by gender and age, and the groups are comparable. There are no statistically significant difference between the groups by direction of the disease. The groups are comparable. The direction of disease is about 13 years in group where patient gets cell therapy after operation. The direction of disease is about 9 years in group where patient gets cell therapy in the perioperative period and in control group. Almost all patients underwent endoscopic polysinusotomy. According to medical indications, septoplasty and turbinoplasty were performed. The injection of stem cells once introduced as a mucosal injection of the nasal cavity, which was practically unchanged by the pathological process. The injection volume was 1 milliliters, 10-15 million cells into each half of the nose. Mesenchymal stem cells with improved immunosuppressive properties underwent quality control before its introduction. Morphological parameters, immunophenotypic parameters, and immunosuppression were assessed, and each culture underwent sterility control. 71% of patients in group where patient got cell therapy after operation get autotransplantation. All patients in group where patients got cell therapy during perioperative period get allotransplantation. The most common complaints in patients of all groups at initial treatment were difficulty in nasal breathing from 86 to 100%, colored nasal discharge from 41 to 62%, anosmia about 50% in all groups. We obtain statistically significant difference in the groups up to 6 months after surgery for difficulty is nasal breathing. In the groups where cell therapy was carried out along with the operation, difficulty in nasal breathing didn't occur. In the control group, it was 33%. According to colored nasal discharge, in the group where cell therapy was carried out along with surgery or during the perioperative period, 15% had colored nasal discharge, and in the control group it was 57%. Hyposmia occurred in 57% of patients in the control group compared to 15% in the main group. Using cell therapy in additional to standard treatment of chronic rhinosinusitis with nasal polyps for up to 6 months statistically significantly subjectively improves nasal breathing, reducing the intensity or amount of colored discharge from the nasal cavity, and improves the sense of smell. We obtain statistically significantly difference between the main groups compared with the control group during endoscopy of the nasal cavity in the number of polyps, nasal discharge, and edema according to the Lund-Kennedy score. You can see endoscopic condition of the nasal cavity in a patient after surgery and cell therapy at different stage. Using cell therapy in addition to standard treatment improves the condition of nasal cavity according to endoscopy. We obtained statistically significantly different in the group where cell therapy was carried out along with during perioperative period compared with the control group. During endoscopy of the nasal cavity on days 6-7 after surgery, again the background of nasal irritation with physiological solution 2 days after surgery. In the main group there were significantly fewer crust and discharge. Using cell therapy in addition to standard treatment of chronic rhinosinusitis with nasal polyps improves the course of the early postoperative period. We obtain statistically significant difference in the average value of the specific gravity of lymphocytes in nasal discharge according to the examination. Microscopy of stains microslides, rhinocytogram, up to 6 months. In the group where the injections was carried out during perioperative period, amount of lymphocytes was 13%, and in the control group it was 33%. Using cell therapy in addition to standard treatment statistically significantly decrease in the activity of chronic inflammation during cell therapy by rhinocytogram. In the control group, inflammatory infiltration was moderate or severe. There were signs of activity of the inflammation process. In the main group, the severity of inflammation infiltration was characteristic by a weak or moderate degree. Symptomatic activity in the inflammatory process was absent in the main group. Preliminary analysis of histological preparation of sample of the mucous membrane of the nasal cavity indicate a decrease in the degree and activity of the inflammatory process in the mucous membrane of the nasal cavity in patients during cell therapy. The good efficacy of cell therapy allowed to recommend it in addition to standard treatment of chronic rhinosinusitis with nasal polyps during surgery due to confirmation of effectiveness on the base of improved of nasal breathing and smell and sense of smell, decrease in intensity or amount of color discharge from the nasal cavity after 6 months of observation, the best endoscopic pictures of nasal cavity according to the Lund-Kennedy score due to reduction of discharge, edema, and polyps after 6 months of observation. The decrease in the amount of discharge is greater in the early postoperative period. Reduction of inflammation according to observation microscopy of the cellular composition of nasal discharge after 6 months of observation. Reduction of inflammation according histological research within 3 months. Thank you for attention.
Namaste. So I'm Dr. Amulya and I work at JSIS Academy of Higher Education and Research, Mysore, Karnataka, India. So my topic for today is steroid-eluting nasal implants in rhinology. Evidence synthesis 2010 to 2015. Next slide. Please change the slide. Next slide, please. Caroline, please change the slide.
Just a moment, we'll check and share your screen.
Yeah. As I say next, please change the slide. Yeah. So the objectives of my presentation today is firstly, the evolution and mechanism of steroid implants. Second, evidence synthesis. That is 40 studies, including RCTs, observational studies, and in vitro studies, clinical outcomes and safety profile, real world impact and cost effectiveness, evidence based recommendations, and future research directions. Please change the slide. Now, coming to steroid-eluting implants. So, bioabsorbable PLGA polymer matrix contains the matrix of polymer which is bioabsorbable. There are various materials like PLA, many other materials, but the most suitable material and most commonly used material is PLGA. After many researchers, they found that the best steroid that can be used is mometasone. So they have used 370 microgram of it, and which has shown a drug release of for 30 days. So that this kind of steroid-eluting stent has dual roles. That is mechanical stenting and local anti-inflammatory deliveries. The FDA devices are Propel, which is being used in the ethmoid sinus, Propel Mini for the frontal sinus, and Sinova, which is also used for the ethmoid sinus. And this Sinova can be implanted in the office. So it is a daycare procedure. Please go to the next slide. Yeah, coming. So initially in 2011, the first FDA approval stent came out. That was for the ethmoidal sinus. That was the Propel. It was developed in the United States. Next, in 2014, they came up with a stent for the frontal sinus, for the frontal recess. That was called Propel Mini. So all of these are still not being commercially used in large numbers. Next, in 2017, they expanded for endoscopic sinus surgery as indications of various reasons, maybe for recurrences as such. Then in 2022, they released an implant called the Sinova. So we took up various studies, various RCTs, observational studies, and we did a meta-analysis. So this is the Prisma flowchart for the same. So we took a number of studies and then we screened and we took the best studies which we got, the complete studies, and then we studied them. So this is the Prisma flowchart for the same. Please change the slide. Coming to the mechanism of action. So basically there's implant deployment. So the stent, which is a bioabsorbable material, contains mometasone furoate, which is released within 30 days. So this releases the inflammation, the edema, and prevents adhesion and synechia. So apart from this, it also maintains the sinus patency. So what happens is the drug is in the polymer matrix and it is released slowly and consistently. And as it is released, there is also mucosal healing. Please go to the next slide. Now, based on our meta-analysis, these are the outcomes which we came across. First, the post-operative pain. In the you can see the VAS scores. VAS score is for the pain and it is out of 10. You can see here that with implant it has reduced significantly. With implant it was only 2.1 plus or minus 0.8, whereas for non-steroid it was 5.8 plus or minus 1.1. So there was 64% reduction. So based on 6 RCTs, we confirmed that it was a better, it was superior to the non-steroid implant. Please go to the next slide. Coming to mucosal healing and edema, there was significant improvement. So in all these studies, they had studied the mucosa over 1 to 3 months, and they saw that the mucosal edema reduced to, there was only 12% mucosal edema in implants, whereas there was 38% in the control. This says that there is faster epithelialization and reduced crusting and bleeding with the stent. Please go to the next slide. Coming to the Sinus and adhesion formation, it's studied in this, they have seen that the Sinus rates is significantly reduced, and it's only 5 to 10%, whereas in controls it was 20 to 30%. So the relative risk was only 0.42%. Go to the next slide. Now studying the polyp recurrence and the revision surgery, they studied 12-month outcomes and they found that the polyp recurrence was significantly reduced. So P value was less than 0.001. So there has been a benefit, greatest benefit in CRS with nasal polyposis. Please go to the next slide. Now patient reported outcomes. Coming to the SNOT score. So there was a significant reduction in that. No score also showed a significant improvement. And there was reduced in need for systemic steroids. Hence, there was an improved quality of life. Please go to the next slide. Coming to the safety profile, so there was reduced in the adverse effects. Incidence of infection was 3%, transient edema was 6%, and device extrusion was less than 2%. Hence, there were no serious complications. Please go to the next slide. Now, coming to the real world evidence of 24 months. So, in a place where there are, most of them are working professionals and people do not have time to visit the doctor repeatedly, I would suggest that steroid electing stents is the best option. That's because it reduces the post-operative visits, the need for oral steroid courses. So when you're not taking oral steroid courses, then you're not leading to any of the side effects of the oral steroid courses, and reduce antibiotic use. Hence, this resulted in cost effectiveness. Please go to the next slide. Coming to the current indication, this is level 1 evidence that it can be used in postoperative endoscopic sinus surgery for the ethmoidal cavity. Frontal recess surgeries, you can use Propel Mini, and you need to select the right cases in case of CRS with nasal polyposis in high risk recurrence that has benefited a lot. And Sinova has been used in office polyp revision cases, but in limited. If it is limited to the ethmoidal sinus and it is minimal, then you can use the office-based Sinova. Please go to the next slide. Now, though the steroid electing stent has a lot of benefit, there are some limitations. Device heterogeneity, short follow-up, that is only for 24 months. So we do not know what happens after that. Industry sponsorship bias. We do not have lot of sponsorship from the companies, and in a country like ours, which is still a developing country, things are really in a research phase because these are very expensive and not available in our countries. So we are still working on that and trying to develop our own indigenous stents. And we have limited data about pediatric cases. Not much stents have been developed for pediatric cases. And the cost effectiveness variability, in the sense that the stent is costly, but everything else, the expense for everything else is cut down, because there are no lesser post-operative visits. You're not taking oral steroids, you're not taking antibiotics, so all that cost is reduced. So we are trying to develop indigenous stents in India. Please go to the next slide. Next slide. Coming to the future research priorities. So we need to develop long-term multicentric RCTs, and we need to compare head to head, because we do not have many stents to compare and standardize. We need to standardize the outcomes, because these have not been being used commercially and regularly for surgeries. We are still in the naive, in the initial stages. So, and we also need to do the cost effective analysis and also develop novel steroid formulations, which we are doing and working on, so to make it more cost effective. Please go to the next slide. Now, coming to the clinical recommendations. So, routinely you can use it for high risk endoscopic sinus surgery patients. You can use Propel Mini for standard, Propel Mini standard for frontal sinus cases, and it can be used in CRS with nasal polyposis in revision cases to prevent recurrences. But you should be very careful when selecting the patients, because they need to be compatible with the stents, and they should be compliant, and you should be compliant to use it for 30 days. So, and we need to monitor the 30-day post placement, and if they do not come for follow up to look for the placement, then it's going to be difficult. Please go to the next slide. So here the key takeaway messages is that steroid-eluting nasal stents have been proven to have short-term benefits, excellent safety profile, reduces healthcare burden. It's an emerging standard of care, but we need long-term data. So if we develop indigenous, cost-effective stents, then that is going to make a real difference for all the ESS patients. Next slide. Thank you, everyone. If you have any doubts, you can contact me. This is my email.
As in the birth of audiology in the years after World War II. Back in the early 70s, there was a reform because we had two different ways of testing hearing, the pure tone audiometry and the Benghazi audiometry. So to kind of set the global standards or the gold standard, they went for the pure tone audiometry. I think Dr. Georg von Benghazi did a pretty phenomenal job also with his development of the Benghazi audiometry, and I think there's a lot. I think that can have a new renaissance in today's audiology, and I see the future of audiometry as happening in a free sound field, because that is the natural way we hear, and therefore it should also be the basis for a hearing assessment. Stanford, recently Dr. Fitzgerald at Stanford back in October 2023 released some research showing that there is no correlation between speech discrimination tests and performed in silence and speech discrimination tests performed in noise. And this is basically telling us we have been testing hearing wrong up until now. And we really have to do something about this, because there, there are 1.5 billion people in the world with hearing loss, and we owe it to them to develop a relevant way to test hearing. And that should be developed in a free sound field. The pictures you are seeing here is not of real equipment. It's ChatGPT that has created these images, but it's to communicate the ID. This is by no means the final design, but it will give you the idea of how it will work, you know. Hero Medical has the solution, and it's what you see here, very simple solution where you got 3 audio outputs, one for signal, one for noise, and one for masking, so you can test each ear individually. The problem, you know, with the decibel scale is that it's logarithmic. And this system can actually test the effect of hearing aids. If you run a speech and noise test first without hearing aids, and then under the same test conditions, same signal noise ratio, a test with hearing aids, you get a decibel value of the hearing aids effect. This is quite important. The problem with a decibel value is that it's not comparable from one client to another client, you know. So we need to calculate over from decibel to percentage. Once we do that, we can get we can start producing normative data on how much better a client with this and that diagnosis and this under this and that socioeconomic relations should hear with a hearing aid, you know. And that is very essential information, and that will be a quantum step for clinical audiology, I think. But I also have this idea of a large language model, but it's not a large language model, but it's kind of with noise, you know. So that we create this database with different noise types, and kind of can recreate this with prompts to clinically be able to recreate a noise environment that the client describes as problematic, or to optimize the hearing aid fittings for their work conditions, you know. And we can kind of recreate the working conditions with prompts. That I think that is the future, and that is kind of what I'm hoping to see in the future. You know, it's an invitation. Hero Medical Incorporation Incorporated is not a is no has nothing written in stone. It's an invitation. Come help us recreate audiology. You know, the late Professor Oren Harari from the University of San Francisco once said the electric light did not come from the continuous improvement of candles. And I love that quote. And I really think it fits the state of audiology today. We can do so much better, and we can make we can make an audiometry that actually answers the questions of clients. You know, every doctor here that works with hearing aid clients has at least a client a week that comes with the sensation that their hearing has deteriorated. But we test them with the pure tone audiometry and find no change. And then I have to cover this quote from Schuknecht and Garcek back in 1993. They wrote, the pure tone audiogram can show normal auditory thresholds with only 10% of the auditory fibers intact. And this is quite important information, I think. The pure tone audiometry is made for measurements in silence. It don't take the noise into considerations. So we kind of need to bring the noise to the clinics. Speech in noise testing is gaining a recognition for, but it's a long way to go. I think on a world basis, we're talking about 30% of clinics performing speech and noise testing. This has to be done everywhere, in my opinion. And what better way to do it than to create a new way, new method for hearing testing. No field is stronger than its source of information. This is a quote by me, actually, and I think that is so true. And the pure tone audiometry has been, it's way overdue. We have known the quote I just mentioned by Schuknecht and Garcek is just one out of multiple quotes in the scientific literature pointing to the fact that the pure tone audiometry is inadequate. We have to rethink audiology as a whole. And the way to do that is to remove the traditional headphones. Develop multi-response solutions. We can have a EEG response, and then you have the client response, you know. And I would love to see the Benghazi audiometry developed for free field testing. I think that could be would give the method a new renaissance, kind of. And this can have implications for multiple fields in medicine, you know, not only audiology. to measure when the body is hearing and how long it takes before the client responds is very valuable information. It tells us something about motorics. It tells us, yeah, it can be a lot. I always say it's not what we know that is important. It's what we can learn. And my solution kind of opens a new universe of new knowledge, new ways of testing hearing, new we can develop multiple things. There's kind of no limitations anymore. While the pure tone audiometry has become a bottleneck for further progress in the field of audiology. And I think it's important that we bring in all multiple fields of medicine to develop this, you know. And I think neuroscience has a very important role. But I think consult with everybody, you know. The more we consult with, the better, I think. But I'm very excited to see how the Benghazi audiometry performs when it's transformed over to a free sound field. I really think that that's really exciting. So I'm raising money now, hoping to get this prototype built and show proof of concept, because you know there is a lot of proof of concept on this on existing speech and noise research. But I am kind of challenging the recommended listening distance, which is set to 1 meter due to the wavelength of a 250 hertz sinus tone. But I think, yeah, there's a lot to be done here. When we look at AI, which is kind of accelerating both product development and the possibilities, new possibilities, you know. I think it's very exciting, and I think it's the right time to transform clinical audiology. But for that to happen, we have to bring people together. So please, if there's anybody here today who wants to be a part of this, please reach out to me on LinkedIn or through the organizers here. And I'm happy to discuss this further. I don't know how much time I got left.
Everyone, what is color blindness? I will appreciate them who will want to answer this. Okay, let me explain this. People when think or when hear the word of color blindness, they start thinking like that people who are colorblind, they are not able to see any color. But this is a totally misconcept of these people who are thinking like this way. So what is color blindness? Color blindness means that a person has trouble seeing some specific color, like it could be red, it could be green, or it could be blue. Most people with color blindness can still see colors, but they may mix them up. It is very rare for someone to see no color at all. So, color blindness is also called a color vision problem, and it can affect daily life of colorblind people. So, what is the types of color blindness? Now we learn about the different type of color blindness. First is trichomacy, which means normal color vision. People can see all three colors normally. Sorry. Second is anomalous trichomacy. These people can still see all three primary colors, but one of the colors look weaker. If red is weak, we can call it protonomaly. If green is weak, we call it deuteranomaly. If blue is weak, we call it tritanomaly. Next is dichomacy. Dichomacy, which means that person can only see two of three main colors. Here, one of the cone is completely missing or absent. If the red cone is absent, is protanopia. If the green cone is absent, is deuteranopia. If the blue cone is absent, it is tritanoponia. Finally, we have a rod monochromacy, where a person has no cone cell at all. They cannot see any color. This cone helps us to see the black and white color. The physiology of seeing any colors, the retina contains two types of light detecting cell. We know this is one is rod cell and one is cone cell. Rod cell helps us to see black and white color, and cone cell helps us to see the other colors. So normally there are three kinds of cone, each containing different pigment which are activated when the pigment absorb light from the outside. These receptors are often called as cone. There are three types of cone: as cone, am cone, and al cone. For short is uh, responsible as cone. Amcon is responsible for medium wavelength, and alcon are responsible for long wavelength. But they are also often referred as a blue cone, green cone, and red cone, respectively. Now we will discuss about the causes of color blindness. This is the most important factor to know what is the cause of color blindness. Okay, color blindness can happen for two main reasons. The first cause is genetic, and this is the main or most common reason. I am researching only one topic about color blindness for the 7 to 8 years. Uh, what patient I got in my life all are related to genetic problem. The first cause is genetics, meaning it is passed down from parents. Red, green, or blue color blindness usually comes through family genes. I repeat again, red, green, or blue color blindness usually comes through family genes. The gene for color vision is on the X chromosome, the sex chromosome, which is why more men are affected than women. Because X chromosome, man has one X chromosome and woman has two X chromosome. Women usually carry that gene but don't always show the condition themselves. That's why we sometimes we say mother were carrier, mother not colorblind but mother were carrier. If a mother carries the gene, there is a 50% chance that she can pass color blindness to her son. The second type is acquired color blindness, which happens later in life. This can be caused by aging or eye disease like glaucoma, macular degeneration, or diabetic retinopathy. It can also be caused by eye injury or side effects from some medicines. If someone has if someone has inherited colorblind pattern. Now I would like to talk about inheritance pattern. What is inheritance patterns? If someone has inherited colorblindness from birth, it is usually stays the same for the whole life for the person. It does not get better or worse. Red green colorblindness usually comes from the parents, is passed from the mother to the son through the 23rd X6 chromosome, which is the known as sex chromosome. Carry our genes, and genes are like instruction for building our eyes and other organs. If someone is colorblind, uh, it means the cone may be missing, weak, or the pathway from the eye to the brain did not form properly. For a male to be a colorblind, his X chromosome must have the faulty gene. Female have a 2X chromosome. We discussed already. So if one has a faulty gene and the other was normal, the good one makes up for it. So female could not be colorblind. However, a daughter can be colorblind if her father is colorblind and her mother was carrier. So colorblindness is typically follow a genetic pattern, especially through mother's chromosome. Now we will see if the father, colorblind man, and the non-colorblind woman, if the father is colorblind and mother is non-colorblind, so what will be the result? One son will be colorblind, two sons won't be colorblind, daughter will be carrier, one daughter will be carrier, and if the father is colorblind and mother is carrier, then one son will be colorblind and one son will be healthy, and one daughter will be colorblind and one daughter will be carry the colorblind gene. Now, what about the non-colorblind man and colorblind carrier mother? Then the son won't be colorblind, one son won't be colorblind, and one son will be colorblind. One daughter will carry the colorblind gene, and one daughter will be healthy. Now now I would like to talk about non-colorblind man and colorblind woman. One son must there will be two sons must be colorblind, and one the two daughter will carry the colorblind gene. So how we diagnose the colorblind patient? We all know about Ishihara plate. If in this presentation, if anyone are unable to see this plate, they will be recognized as a colorblind. Is there anyone who are not able to see this plate? Is there anyone? Okay, this is a good news for us. There are no colorblind except me. So I did a research in Bangladesh, and now I would like to introduce myself. I'm the very first person in Bangladesh who developed colorblind glass, and I'm the first person in the world who developed colorblind mobile skin protector. And in the 2024, I also designed a colorblind contact lens for the people who are colorblind. They can put the lens, and from the outside, no one can be detect he or she put lens or not. So what we got the result from our country, we took 10 participants. Then we give them the 38 ECR plate. The first result, the first person was able to see only 6 plate from the 38 plate when we give them our own glass, vibrant colorblind glass, which developed by me. After wearing this, the same person was able to see 32 plates from 36 plates. This is the very improving result. And if we talk about the last person, the number 10 person, he was able to see only the 5 plate from the 38 plate. When he put our own vibrant glass, then he was able to see 33 plate from the 38 plate. His improvement was 74%, which was significant result. Now the term, people want to know how colorblind people see the things. You can see I give 4 picture in this slide. Normal people can see this, and poor red vision can see this, and the poor green vision can see this. I already mentioned the all caption behind the below the image. So we can difference one more picture from this. This is a difference from a normal person and a colorblind person. I took the references for my slide and I put here. Thank you everyone. Thank you everyone for listening me and giving me time. If anyone have any question, you can ask me.
Yeah, yeah, you can start with the slides, and once I say next, you can go ahead. So my topic will be doctorpreneur journey, merging medicine with aesthetics. So as I have already discussed earlier, like why every ANT surgeon or any even MBBS doctor should have a med spa and should incorporate aesthetics into their practice. Basically, as an ENT surgeon, you keep on continuously working on the area of head and neck region, and you are very well acquainted with the anatomy. And these days, with the concept of med spa in developing countries, a lot of malpractices have been happening. Even the regular beauty parlors or salon people are incorporating this into the practice without proper training and without proper qualifications, and even non-medicos are performing all these things. And being a doctor, it's our responsibility that we train people, we give right advices to the people, and we make available the quality services for all our patients. So, what is a doctorpreneur? So, it's any medical professional who combines his clinical expertise not only with the treatment of the patients, but also with the entrepreneurial vision. And it's just not confined to treating illness or doing surgeries, but also focuses on regenerative medicines, wellness, and beauty to build a basic, sustainable, ethical practice and a patient-centered business so that both ways everybody's are benefited. Next slide, please. So, if you see, even in India, also these days, we have a lot of new age doctorpreneurs in abroad, also like countries like Turkey, Europe, USA. All the facial plastic surgeons or ENTs or ophthalmologists who are into non surgical and surgical practice, they are not only doing surgeries or not only treating their perspective part, but they're also starting with the business of producing their own brand for medicines to give proper formulations which they want their patients to provide, and also expanding the healthcare facilities beyond their own city. So next slide please. So these doctors, they are not just just doctors, they are the leaders, the investors, and propagating the field of medicines all across the country. So why into aesthetics and why a med spa we should have in our practice? See, these days aesthetic medicine is creating a revolution. Patients are seeking for non-surgical as well as surgical confidence-boosting treatments. Although in India, in Tier 1 cities, it's up to boom, but Tier 2 and Tier 3 cities are still, lacking behind. And now the patients are more for preventive services. They want wellness to luxury and they're having a shift in a healthcare perception. Even if you see the statistics, the global aesthetic industries has gone beyond 60 billion market, and it's still rising and rising, as you can see through Instagrams and social media as well. So we can clearly see that there has been a preventive and enhancement based care, a natural looking face, a natural enhancement based care is coming up. And even the non surgical treatments like Botox, fillers, lasers, PRP, microneedling, they are all into coming and taking the boom, because many a times people are scared of getting under the knife and they want something, minimally invasive. So for that purpose, these things, these injectables, these aesthetic procedures are going to increase, and as soon as the awareness will be spread out, this will also increase, and patients will seek the confidence and natural results. Next slide, please. Next slide. So to understand this, we should know a little bit about a science of aging. We all know it, but just to have a little bit of orientation, because in this, everybody will be our patient. Even if a child is born, it's called a 1 day old. Then we come to the teenagers. These days, the lifestyle of teenagers have, really affected due to increased screen time, lack of posture, and due to, habits like smoking, drinking, drugs, and all, not having adequate healthy lifestyle and nutrition. Even the early youngsters are having a lot of collagen loss. If you see, their eyelid will be a little bit saggy. There will be a little bit of early onset of dermatocolidosis, and as soon as we grow up, naturally also our collagen and elastin, we lose it. Once we are into 20s, we are in a good shape. Our collagen and elastin fibers are very well arranged. But as we go towards the end of the 30s and 40s, this becomes depletions happens to of 10 to 20% every year, depending on the lifestyle and stress and dietary factors of the patient. And by the age of 60, it goes beyond. But these days, it is coming towards early onset of, especially the upper mid phase aging is going on very early. So it's time, in the aesthetics, you will have everybody who will be your patient, because aging is inevitable and it will occur to everybody. So it's a huge market out there. Next slide, please. Next, yeah. So why do we excel here? See, these days, as I mentioned earlier, even the salon people and non-medicals are also doing that. But being a MBBS or being a ENT or a MaxFax or a qualified, professional, if you are, you have a more chances of giving patient optimum and rational choices of a surgical as well as non-surgical aesthetic procedures. And as we know the anatomy, it has already, it builds up the trust. We know where not to go, where not to, where will be the sites which will be risky. So it becomes quite easy for us to gain the, artistry of injecting. And even if somebody is into non-surgical also, they can learn as well. So that's gives us a very trusted authority for ethical and evidence-based practice, as compared to any, non-medical saloon or a person who is not into a medical field. And it will blend your medical precision with the artistic sense. So it's not only, it's boosting your own skills, but it's upgrading your skills and enhancing your horizon of practice. And although it needs continuous learning and skill upgradation, and being a doctor, you are always a student. So why not one should learn and go ahead and, give maximum services to our patients. Next slide, please. Next. So, if you see in a broad, even this injectables and aesthetics, it comes into a allied specialty. A lot of people who might be in abroad, in India, it's not so. So even as a medical professional, even an MBBS doctor can also do a PRP or laser or skin rejuvenation services after the proper training or proper fellowship. And even the nurses are opening. There are a lot of examples. I have just put up one, but there are a hell number of people who are running med spa. So why not being an ENT surgeon? You have your own, at least you already have a minority, right? So why not just upgrade your practice and incorporate aesthetics into your practice, because it is just the art of injection, injection in the right way. That's it. And being a surgeon, you have an advantage of learning autologous fat drafting as well, and you can do it very easily by proper fellowships. And there are many more examples of the people who are doing this. So one should broaden their horizon. Next slide, please. And the people are showing, next slide here. So people are so good. Like if you see his profile, he's doing good surgeries, he is creating his own skincare brand. He has staff nurses. They are, running his med spas. This Dr. Chia Chika, and there are like many more are there. I have just taken his example. There's Dr. Karam MD. There's Dr. Imre Ilhan. There are a lot of people who are doing even so. This, because of this, increasing trend of aesthetic procedures and deep understanding of anatomy, these are leading in aesthetics. So it requires a continuous learning and skill upgradation, but everybody will can easily incorporate at least injectables practice. Next slide, please. Next. So only thing we require is just a vision beyond our clinical work, understanding of a little bit of a branding, patient experience and marketing, and use of AI, digital consultation and teleaesthetics to grow your practice. It's not necessary that everybody will be launching skincare, but still you have a very good scope of, you know, of widening your horizon of having med spa. Next. Next slide, please. So then the questions comes that how we are going to start. So first you have to identify your niche. If you are into surgery, go for a surgical fellowships. Either you are Max Fax or a plastic surgeon or an ENT surgeon. You can, or if you are just a plain MBBS doctor, they can at least start with an injectable practice after doing a fellowship, and this requires not much. There's no too much of this PRP, this body contouring through equipments. They don't require too much of training. They're very easily you can learn and get certified with various fellowships and workshop, and you don't have to think for a big volume. You have to go for a classes and not masses, because these kind of patients who want to get aesthetic services, especially in country like India, they see it as a luxury. So we have to invest in a quality based devices and create a very overwhelming patient's experience, so that they not only seek treatment from you or surgical, they also go for non-surgical and body spa as well, so that they will be on the right hands while under your guidance to have appropriate and rational treatment. Next. Now this is helping not only in your surgical practice. Even the if you're offering more services, your name is also propagating. You are growing early. You have exponential growth after this when you go for the non-surgical treatment as well. For example, you can start with even a simple hydrofacial or a medifacial device. It depends on you that how much amount you want to invest. If I see it can comes in like original hydrofacial MD, it comes around 25 lakhs Indian rupees, and the cheaper ones are very cheap. But still, if you will be doing it, you will be using the rational serum. You can play the video. So in this, if you see, it's just a medifacial. My staff nurse or assistant nurse is doing it. This you don't have to do it. This is a medifacial which will help and keep the patient in the anti-aging mood. I hope lots of people in the other countries might be getting this done. And this is completely based on antioxidant serums, radiofrequency, and medical grade devices. So in India, it has come up in last 5-10 years as a new concept, but every doctor can have it. Now, being a surgeon, why you should have it? See, whenever you are doing any kind of pediatric surgery, thyroid surgery, or you are going over a blepharoplasty or even a rhinoplasty, you want your surgical field to be clean, right? You want your skin to be healthy. Next slide, please. You want your nose to be comedons free. Next. You want your nose, play the video. You want your nose to be, comedons free. Only create a very sound, clean surgical field before your surgery. Not only it is just adding your revenue, but it is also creating and building the trust, and it's also enhancing that it is also decreasing the chance of any kind of hypertrophic scar or post-inflammatory hyperpigmentation at your scar after the surgery. So that's why medifacials are very economic and easy thing which you don't have to do directly by getting it. You have to just decide and invest in the right device. Your staff will be doing it. You will be doing your surgeries and your med spa will be working for you. Next slide, please. So this is one procedure which everybody can have it. And in India, they charge like 2,000 rupees to 5,000 rupees for a medifacial. I don't know about the other countries. They are charging quite higher, depending on whether they are developed countries or developing. So this is a auto mode kind of thing which you will be having in your setup in the same given time. And even if you're not around, say for the upcoming sessions, if the patient is satisfied with the services, they will be keep coming to you. So it's like that. So you can increase your revenue also through this procedures. Now coming to next slide. And also you can, next please. Also, you can start doing micro needling before surgeries because it enhances the collagen production. So, if you are doing micro needling before your surgery, it not only give a clear scar, a better wound healing, especially if a patient is diabetic, but it will also add up revenue and it will create a good rapport with the patient. That even after post surgery, also your scar will be also good. The skin quality will improve, and these procedures are collagen generating. The patient will be keep coming to you. Again and again. Now, the challenges in the journey are that there is a high initial investment and there are a lot of market competition and unfortunately a lot of misinformation. So we have to be into a proper mindset to have a proper balanced clinical practices as well as business role, because being a doctor, you're not into a business and business is totally a different game. So you have to train your mindset, you have to get up into the things, understand the things, and have knowledge of the things going around and upgrade yourself. And most importantly, managing the patient expectations, with what expectation and with what psychology they are coming to you, and satisfying them accordingly with your proper rational advice. Next. So there will be challenges, but with your professional skill, it will definitely going to help you in upgrading, because this is especially in the med spas, it is a low market risk. It's a high demand market, and there's a big opportunity for generating a passive income via trained therapist or trained technician when you have a med spa. So this increases your income. Not only your income is just a byproduct, but increases your professional visibility all around the corner. So that's why I really insist on my ENT colleagues especially to come into aesthetics, to have a med spa, even with a single room or two room areas, at least start having it. And once you get heck of it, go for a bigger one. Next slide, please. Now, another machine which you can have, or a procedure you can have, is a laser hair removal. Now, these days, even the salons are having a laser hair removal, and they are doing without any trained machine. They are using very low quality machines which can even create burns. So, being a doctor, it's not only your responsibility to give a quality care to the patient so that they don't go at wrong places. They are not misinformed. So this laser hair reduction device of any good brand you can have, I use it for Almas. You can have according to your wish, and you can either do it yourself or you can train your skin therapist to do it. Now, why? Because everybody has hair growth. Everybody wants to look clean and nice, say it boys or girls. So everybody among, like, if you convert them, every patient is for this laser hair reduction. So this is also one of very nice machines you can have in your setup, and you can go ahead with the process. Next slide, please. So again, the staff will be earning for you, and the others are lasers like a Q switch or pico lace lasers. So these are used for laser toning, for skin brightening, for tattoo removal, hair bleaching, freckles, hyperpigmentation, brown spots. So is this either you can do it or you can go ahead with this, your trained skin therapist, and decide your parameters according during your consultation and go ahead with that, because this is also very rejuvenating and without any downtime. So again, it's a good choice to have in your setup. Next. Now, a lot of people these days, for example, India, if I'll name the chain like VLCC, Gucci, they're like Pacholi, they're like a lot of Indian brands who are into wellness, but they don't have qualified doctors, supervising it. Or so being a surgeon or being a medico, you have a better perception of all the things. So these are all the high fem device using high field magnetic radiation and lymphatic drainage devices. This is the endospheres. If you see the other one with the roller, this your staff will be doing. Again, it will create your practice into auto mode. A lot of wrong, like a lot of wellness brands are earning a lot of money from this. So why not, being a surgeon, you should have this, or being a medico, you should have that in your clinic, and let your staff do it. You decide the parameters. You properly plan and supervise it, and gain and add up into a practice. This lymphatic drainage is anyway going to help you, not only in patients blood improvement of blood circulation, but also overall health of the patient. Next slide, please. Because of these days lifestyles is very stressful. Everybody is into lifestyle diseases as well. Now, another treatment which you can have is hair restoration treatments. Now, hair fall, especially in men of younger males these days, are coming to in our region. The younger guys of 20 years, 30 years are having a lot of hair fall. Even the females also. So they will have a temple show, or they will have a temporal baldness, or receding hairline too early, or scalp see through. So you can have a lot of good injectable hair restoration treatments like a PRP or a growth factor, or you can use stem cell therapy if you are trained, or you can buy exosomes for say. And even if you have any kind of therapist or PMU artist, you can go for scalp micropigmentation to camouflage the bald patch or beard area. And of course, if you're trained and if you are into expertise, then you can have a tie up with the other surgeons, and they can come and do a hair transplant at your setup. So by this, you can tie up and enhance your practice and widen your horizon of giving the services of your for your patients, and this also increases your credibility and your visibility. Next slide, please. So there are a number of doctors who are building their reputable aesthetic brands, not only in terms of just their surgical suites, their med spa, or their skincare or their healthcare brands, but they are creating a good impact on patients' health confidence also. And it's increasing their positive social influence and innovation. So why not you? Next slide, please. So once if you are into, they are all, the market is very upcoming. You're having personalized treatments like AI based kinesis. The regenerative aesthetics is coming to boom now. The stem cells, people want to get stem cells infusion, SVF also. And you can also integrate the other branches into your med spa, like for nutrition and a good dietitian or a psychology. So these are all doctor-led innovation. So don't let non-medicals, guide patients in a wrong way. But being a surgeon, being a medical profession, you can have a global collaboration all over and enhance your practice. Next slide, please. So there are a lot of boosters also coming over there. So only thing you have to do is to choose a right product and decide a right product for your patient. So there are stem cells in SPF. If you are a surgeon, you can learn autologous fat grafting. That's most easiest to do, and the patients are also very comfortable. Only thing is that after fat harvesting, there might be some subtle discomfort for 10 to 15 days to patient, depending on persons to person's pain threshold. Then there are exosomes. They're directly, you can go for an intradermal introduction, or you can get it topically absorbed by microneedling or electroporation through a device. Then you have platelet rich plasma, polylactic, PDR, and polynucleotides. You might have one for salmon swam DNA. These are nothing, just polynucleotides creating better hydration. So why let others, like, yeah, let have it in your practice, so that when your patient is coming, is they're getting treated for everything. And then you have hyaluronic acid for your deep moisturization. Next slide, please. So these boosters, they just require a intradermal injection or a topical absorption by microneedling or microneedling radiofrequency. But the results are amazing. Please play the video. And the rewarding side is that there's immense emotional satisfaction. Mind you, when you're selecting the right procedures for the patient and they are following your advices, the home care, they are taking the nutraceuticals, the results are amazing. And it's also, having it, creating your intellectual growth by mixing and merging the procedures, and it shows your creativity, and it builds your legacy also as a doctorpreneur, and increases your financial independence and flexibility if you see as a surgeon or a doctor. Next slide, please. So the kind of results you have, and the kind of satisfaction you have, not only financially but through the patient's transformation, the patient's increased confidence, and the way they come up to you, oh wow, you have made me so nice. Although many a times patient, they will not speak that to other people that they have got done, they just want to say they are looking natural. But down the line that you are the reason behind their glow and their transformation. So this is aesthetic is something which is very, very meticulous, very easy to do, but you have to have an aesthetic eye and proper treatment. So it's a collaboration of a science, art, and business. And with your ethical practice and investing into quality devices, it's going to bring build your practice as a long term trust with the patients. And continuous learning is a secret weapon. As a medico, we are students forever. We keep on evolving. We keep on, growing. So this entrepreneurship should come to us, and we should evolve ourselves, and we should inspire our future generations, that okay, in our generation we don't used to earn so much. Now we have learned, so we have to propagate this knowledge, the type of doing of rational practices and avoiding malpractices for our future generation, so that they have a better future, especially in the developing countries where doctors are underpaid. So this, I would like to suggest all my colleagues, whosoever watching, please do incorporate aesthetic practice into your, clinical practice. Next slide, please. Or have a med spa. So for even in future, you can have a chance to open a business also. Like you can develop a franchisee also. You can start with a very minimal PRP and medifacial and some option like that, and you can have a chain of your clinic as well. I have started now. I have just started this year only with 2 years. So next slide, please. So you can decide according to your plans, and you can create the brand visibility also, as well as creditability also, when you are expanding your branches and futures. So, and then the break even you are able to achieve in 12 to 18 months. And once you achieve the break even, again expand it, invest in better devices, and the cycle goes on, and you can keep going. Next slide, please. Because you have a high client potential of coming for repeat services. So these are very there are very innovations going on. It's going to help you. So the key takeaways are, it's ideal for all the doctors, surgeons, and even nurses in the outside who are outside India. They are into allied specialties. And we also offer, if somebody is interested, we offer them, we advise them to have a med spa in their existing setup, so that you don't have to go for a new place. Rather, incorporate aesthetics in their own setup and premises. Next. And we believe in growing together. Let's grow together. Let's help each other, because aesthetics is just not a vanity. You will be creating a lot of confidence in the patients as well as the practitioners who will be doing it. Because when you create immediate transformation, you yourself at the down there in your mindset, you are like, okay, this transformation has come up. I'm improving. I'm evolving. This kind of sense it gives you. So if anybody wants to connect with me, they can connect me through the Instagram. This is the small picture of my med spa. Next. Next slide. uh, you can for example, and even if you are like old enough, like if you are into 60s, you don't want to work more, so you can hire people for you. You can hire trained therapists, trained doctors under you, and run med spa. Even that kind of setup you can also have. And you can have a break even at 12 to 18 months, and at least 30 to 40% profit margins whenever you have a optimal patient. So this also one can have as a, if somebody is not directly into too much of medical practice, or they don't have time, they can get involved by themselves. They can get it, they can have it indirectly also, by either opening their own chain or in having their other people's chain. Next slide, please. There were two more slides.
No, doctor, that's the end of the presentation.
Okay, so I also conduct fellowship programs for 5 days injectables and aesthetic training. So if anybody is interested, I can drop it in the chat. Ms. Caroline can share, and if anybody is interested, they can come to us for 5 days fellowship. So thank you so much, everybody, for watching, and I hope you find it useful. And even if one of you is interested in facial aesthetics to incorporate in your practice,
I'd like to speak about the role of using propolis supportive therapy. I'm a senior AI and ML researcher and pharmacognosy expert, and I'm working on as a dynamic leader in AI-driven pharmacognosy with more 10 years bridging a traditional ethnomedicine and modern ML for drug discovery. I have PhD in ancient creator of ethnomed advisor, the project with the Google generative AI capstone 2022, 25, sorry. And I have many awards, gold medal in INA and ARCA and the WIBO Global Figures Award. About the traditional healing properties of bee propolis,
Sorry for the
honeybees
interruption,
create
doctor.
propolis by collecting.
Your screen is not visible now. Could you please check it?
It's okay? It's okay?
No, it's not.
What's the problem? I'm sharing my presentation. It's visible for you?
Yes, it's visible now.
Okay. Honeybees create propolis by collecting resin from the tea bark and leaf buds. This resin formed to protect buds from fungi and diseases are chewed mixed with enzyme and beeswax and used in the hive. Ancient Egyptian working on using the propolis for keeping the body of the human body, and propolis means in Greek, ancient Greek, front the city or the city shield. One beehive produce about 25 to 30 kilogram of honey and sugar, so that there is must be a substance injurious, so that the propolis is this a very important substance to keep away the infection from this hive. Propolis ramps the immune response in honeybees infected with bacteria. The social immunity is a key factor for honeybee health, including behavior defense strategies such as the collective use of antimicrobial plant resin. A study in China found about 5,000 local beekeepers possible due to propolis use. Further control laboratory studies are needed to confirm propolis' role in preventing viral and bacterial infection. So that our goal in this study to development a green extraction method and using it to as an antibacterial side by side with the antibiotic, because the resistance of antibiotic, especially in the respiratory tract infection in our country, it's huge. And according to UN SDGs, to use a green chemistry by extracting the propolis from the bee honey. So that we did this study and make from the raw propolis powder dissolution and then make a study about the efficacy, and then underscored the propolis potential as natural supporter in treating bacterial infection. Propolis collection as chemical analysis and free radical scavenging activities show us that the bacterial isolates used in this study were obtained from clinical samples at Aleppo University, and the standard antibiotic used in a study there is many antibiotic, vancomycin, ampicillin, augmentin, and chloramphenicol, ciprofloxacin, zitromycin, gentamicin, and cifbin. Propolis was collected from the northwest countryside of Masyaf in the western area in the Syria. and using the vinegar water extract to determination the total phenolic content and the flavonoids. Then the antibacterial efficacy was tested against certain pathogenic bacteria, comparing with the standard antibiotic by using a Kirby-Pyre method on Staphylococcus epidermis, Arius, and Pseudomonas aeruginosa, and E. coli. Here we find that 5 basic phenolic compounds were identified in the studied extract of Syrian propolis, and there is 8 essential organic compounds, fatty acids, sterol, and terpenes were identified in the studied extract of Syrian propolis. This slide shows a total phenolic comparing with the garlic acid standard series. The percentage of total phenol in the extract was calculated term and was 299.31 milligram. Antioxidant activity, the DBPH assay is 74.89 percent. Here we find the antimicrobial activity of the aqueous vinegar propolis extract, where the diameter of bacteria inhibition zone was recorded in millimeter, and the anti and there is 3 replicates with the results show us that diameter of the inhibition holes range from 18 to 20 millimeter towards gram-positive bacteria and 12 to 17 millimeter toward gram-negative bacteria, as we've seen for the pathogenic bacteria. The antimicrobial activity of this extract is higher in relation to gram-positive than gram-negative bacteria, and there is many of bacteria has resistance to the antibiotics used as a standard antibiotics. The antibacterial efficacy of this extract against Staphylococcus aureus is comparable to that of imitamab, and vancomycin against Staphylococcus epidermis is similar to vancomycin, and selected antibiotics against E. coli in according to chloramphenicol, and against Pseudomonas aeruginosa exceed most antibiotics, except imitab, and ciprofloxacin, and gentamicin. The extract, both of the extract has many compounds than the aquatic and the ethanolic extract, comparing extraction method. And here the structure of the chemical composition which lead to the antibiotic efficacy, so that the study also highlighted the richness of Syrian propolis in phenolic content and its importance to a natural antioxidant, making it a key component for enhancing human health and treating diseases. The organic propolis extract show greater antibacterial activity against gram-positive bacteria compared to gram-negative bacteria, and compared to the anti-chemical profile of propolis extract show us that the absence of several components in the ethanolic extract suggests that our extraction method it's better than the using of alcohol in preparing the extract, and we develop a green extraction method. Then we take a patent about our extraction method and make a healthy functional food with propolis considered as antioxidant and supporter the antibiotic or using it for immunity, so that we have to use the functional food with natural potential antibiotic to make the resistance lower than by using this natural extraction. Thank you very much for your time, and I'm ready to any question. Do you hear me?
In Russia, in Tula Hospital, and I am a PhD student at People's Friendship University of Russia. Today I want to talk about Scarless techniques for tumor removal of parotid masticatory and submandibular regions, patient satisfaction and surgical outcomes. To introduce my subject, I have to talk about neoplasms of parotid gland. It accounts for 75% of all salivary gland tumors, with only 20 to 25 of them malignant. The optimal treatment for parotid gland neoplasms is surgical removal, which may accompanied by subtotal or total gland resection, or only tumor removal. The surgical management of benign parotid gland tumors has undergone significant evolution from a procedure based solely on oncological radicality to an approach increasingly focused on achieving optimal functional and aesthetic outcomes. The key objective of modern surgery have become the use of aesthetic incisions, the restoration of natural facial contours, the prevention of phrase syndrome, gustatory sweating, and the preserving of the motor and sensory function of the facial nerve. Despite of variety of proposed reconstructive techniques, each has certain disadvantage. Old concepts of parotid gland surgery. Surgical methods for treating benign parotid gland tumor have actively evolved over the last 50 years. The literature describes various names for these procedures: total resection, subtotal resection, extracapsular dissection, partial parotidectomy, subtotal superficial and deep parotidectomy, as well as nerve-sparing parotidectomy. The choice of surgical extent depends on the tumor's location and size. However, it is generally accepted to remove the tumor along with adjacent macroscopically unaffected granular tissues. Parotidectomy, the removal of parotid gland, was first proposed in 1912. Subsequently, superficial parotidectomy was developed in 1940s. For a long time, superficial parotidectomy was considered the gold standard, for treating benign being parotid gland tumors, based on the principle of totally removing the superficial lobe to minimize the risk of recurrence. The classic operation, typically referred to as superficial parotidectomy, begin with the modified Blair or Kaftanovich antigen. Kaftanovich is a very popular Russian surgeon. The key and most critical step is identification of the main trunk of the facial nerve, as it exists, the stylomastoid foramen. This is followed by the methodical layer
Sorry
dissection
for
of
the interruption,
all.
doctor. Doctor, your slides are not moving.
I don't think so. Is it moving?
No, it's in the first slide, title slide.
Okay, I will try to do something. And now?
No, it's still in the first slide.
Mhm. Okay, and what about now?
Still in the same slide.
Okay. I will try to do something. Something changed?
It's moving now. It's okay now.
Okay. So I talked about the neoplasm of parotid gland. We talked about the concept of parotid gland surgery, and we read the classical operation, typically referred to as superficial parotidectomy, being with a modified Blair or Kaftanovich incision. The key and most critical step is the identification of the main trunk of the facial nerve. Classic methods of parotid gland surgery. Okay, the complications of these methods are superficial parotidectomy is characterized by a high risk of complications due to the need for extensive tissue dissection to identify the facial nerve. The most frequent complication is nerve injury, leading to temporary paresis, persistent paralysis, resulting in functional and aesthetic defects, is observed significantly less often. Other reported complications include Ciallos cell, salivary fistula, and Fries syndrome. Additional drawbacks the method are prolonged hospitalization, the formation of a prominent scar, and deformation of the facial contour, which is very important. Totally parotidectomy, which involves the removal of the entire parotid parenchyma, is characterized by a comparable or greater risk profile compared to parietal resections. You all see the photo? Okay, so classic methods always use traditional incidents such as Blair and modified Blair. Here I'm showing these three photos of the of patient who had an operation with blur incision. The shram is still, even after 1 year. Next, modern approaches of parotid gland surgery. You are all with me? Okay. Extracapsular dissection. Extracapsular dissection of the parotid gland in its current form was described by Gliev in 1995. It's a surgical technique that involves the removal of a pathological lesion with a minimal volume of glandular tissue resection, without the need for systematic identification of the facial nerve branches. Initially, the technique was used primarily for small tumors. However, modern research demonstrates its efficiency even for larger lesions over 2.5 centimeters, located in the lower parts of the gland, the tail of the parotid gland, in contact with the cervicofacial branch of the facial nerve in the superficial upper parts, involving the temporal branch of the facial nerve as well as a small tumor around Stenson duct. In such cases, the possibility of performing a limited incision below the earlobe or slightly extending into the periauricular area should be considered. Conducted research demonstrated that extracapsular dissection serves as an effective and safe alternative to superficial parotidectomy for benign parotid gland neoplasms. The safety profile of the technique is supported by comparable 10 years survival rates 98 to 100% in comparison groups, even considering that 5% of tumors initially diagnosed as benign subsequently turned out to be malignant. The oncological efficiency of extracapsular dissection is not inferior to the traditional approach, as evidenced by the absence of statistically significant differences in the recurrence rate. A key advantage of the technique is a significant reduction in the frequency of postoperative complications without compromising long-term oncological outcomes. In new aesthetic and minimally invasive approaches in parotid gland, the evolution of the surgical approaches to the parotid gland demonstrates a transition from traditional techniques, Blair, Cartonovich, Redon, which were based on a unified principle, performing a pre-auricular incision with a various extension into the neck, whether extending along the sternocleidomastoid muscle or other modifications, which left noticeable scars to modern aesthetic approaches. Among the latter, the Rahi approach, the facelift approach, and Appiani approach, among others, stand out. The technique reflects a modern paradigm which achieving an optimal cosmetic results becomes a goal equivalent to the technical execution of the invention. So, Rahi retroauricular hairline incision. All guys, you are all with me? Okay, so you hear me? Nobody's here? Rahi retroauricular hairline incision, first described in 2009. The retroauricular hairline incision Rahi is a surgical approach designed to improve cosmetic outcomes by placing the incision within the retroauricular sulcus and the hairline, completely avoiding a visible preauricular facial scar. This technique is particularly suitable for benign tumors located in the lower superficial part of the parotid gland, providing adequate surgical access while remaining hidden by the auricular and natural hairline in addition to superior aesthetic results. The Rahi approach is used in combination with extracapsular dissection, contributing to a reduction in complication rates, preservation of facial nerve function, and maintenance of parotid gland secretory function. A Piani and facelift approach. The facelift type incision for parotidectomy, initially described by Appiani et al. In 1967, was adapted for retidectomy techniques. Significant progress in the technique occurred in 1994 when Thierry and his friends introduced a modified facelift incision, which has since become a widely used technique. The popularity of the modified incision grew significantly due to superior cosmetic outcomes, prompting many authors to directly compare its surgical efficiency with the traditional Blair incision. However, despite the aesthetic advantages, a persistent challenge with the use of the modified incision remains the adequacy of visualization and identification of the facial nerve, especially for tumors located in complex anterior or superior portions of the parotid gland. Consequently, comparative data on the surgical outcomes of these methods, particularly for tumors in this location, remain limited. U-shaped or V-shaped periauricular incision, first described by A.N. D. in 2018. This presents a modern approach in parotidectomy focused on optimizing cosmetic outcomes. The incision follows the contour of the auricular, completely hiding the scar within natural skin folds and avoiding visible scar on the neck. Studies demonstrate reduced operative time and blood loss compared to traditional approaches with comparable oncological safety. The technique provides high patient satisfaction, however, it is associated with an increased risk of cell likely due to limited visualization of the ducts. Thus, the U-shaped incision is effective option for patients optimally combining radical intervention with aesthetic results. Y-shaped incision, triple flap approach, described in 2022 by Borges. This approach was developed for cases when the V-shaped retroauricular axis provide insufficient exposure for large or distally located tumors. The modification involves adding a short infraauricular incision to the retroauricular incision forming Y-shaped configuration. This enhanced significantly improves the visual field of the operation site due to optimal access to the gland. During the surgery, three flaps are created, which gives the technique its name. Research confirms that approach not only provides adequate exposure of the complete resection of the benign lesion, but also leaves a minimally noticeable postoperative scar, demonstrating its promise for application in parotid gland surgery. We see the photos of this incision, how it could be, and how it can help ethically. Next, I would like to speak about my the approach with which I use, and I not only use but writing like my PhD using it. It's our study. We aim to perform this surgical procedure using a modified facelift incision for mid and lower face as the standard surgical approach. The application of our approach is designed to ensure optimal surgical visualization while achieving superior cosmetic outcomes. This integrated strategy offers several key advantages. The first advantage is effectively eliminate the need for subsequent revisional surgery to correct skin defects, therapy preserving both the psychological and physical well-being of patient. And the second, furthermore, it provides the unique opportunity to perform a concurrent mid and lower facelift should there be a clinical indication and patient desire for such procedure. So here we have a patient with this tumor. We make her operation, we took off this tumor, and then we make a facelift in the both sides. So she came to us not afraid of the surgery as much as she wanted to have a young skin. Research study, materials and methods. This analysis synthesizes the data from the 21 articles and one systematic review. Years of publication. The analysis articles were published between 2009 and 2025, and the systematic review by Yin from 2022 included studies from as early as 1994, providing a very long-term perspective. Number of Article 22 and number of total patients, 2,018 patients. 764 patients for modified facelift incision, 862 patients for modified Blair's incision, 186 patients for retroauricular incision, 132 patients for V-shaped incision, 11 patients for tree-split flap incision, 31 patients for single-port endoscopic incision, and 32 patients for preauricular temporal access. We have some results like modified Blair incision have a lot of complications. For example, temporal facial nerve palsy 10% to 41%, Frey syndrome 3.6 to 12%, ear numbness 37 to 50%, sialocyl or salivary fistula 7%. Overall complication rate to 42.8%. Modified facelift incision. From 764 patients, they have complications, temporary facial nerve palsy, significantly lower than MBI, modified blur incision. Frey syndrome, no, they have not Frey syndrome, and other complication, rare or minimal. Retroauricular hair incision, they have 4 to 20% temporary facial nerve palsy. Seroma or sialocyl, they have from 4 to 8%, and operation time of 150 minutes. Okay, V-shaped incision. They have V-shaped. It has minimal complication reported. Zero facial nerve palsy. No Fry's syndrome, but it's like only 132 patients. It's like not studied enough to have like very strong decisions about it. Tri-split flap, we are talking about 11 patients, minor salivary fistula 9%, one patient from these 11 patients. And another complications. For single endoscopic removing, temporary facial palsy around 3.2%, periauricular numbness also the same. Then preauricular temporal access for 32 patients, we had 75% of mild facial nerve paresis and 37.5% of ear numbness. So, based on the provided numerical data, the modified blur incision is the most frequently documented access of these studies, with data from 62 patients for around like a lot of years. Based on the complication rate, the patient satisfaction score, minimally invasive techniques, especially extracapsular dissection, performed through aesthetic incision, facelift, or retroauricular are better for patient in terms of cosmetic outcomes, function preservation, and faster recovery. Classical superficial parodictomy is associated with a higher rate and wider profile of complications. Common complications are temporary facial nerve palsy, Frey syndrome, and ear numbness. Extracapsular dissection is the best technique for preserving facial nerve function. The shift in practice, the data reveals a clear trend. The classical superficial parodictomy via a blur incision, while effective, has higher morbidity. The modern paradigm is organ and function preserving surgery using extracapsular dissection through a cosmetic incision like modified face lifting incision or Rahi retroauricular incision. Thank you for your hearing.
Thank you, Dr. for your informative presentation.
Of the world. Indeed, I am very cheerful and I am very thrilled that I will share with you my experience regarding one of the dilemmating and controversy issues in the rhinology, which is the extended endoscopic sinus surgery. First of all, let us to start with some of the basic concepts, as it is well known for the all that the nasal polyposis is considered as the inflammatory disease process of the ethmoidal sinus mucosa, as it is well known also from the evolutionary and developmental theory that the ethmoidal ear cells are developed from the skull bone. So the nature of the mucosa of the ethmoidal ear cells is different entirely from the mucosa of the other types of the paranasal sinuses. The mucosa of the paranasal sinuses, as general, it is a respiratory mucosa, ciliated respiratory mucosa that represent the mucociliary clearing mechanism, while the mucosa of the ethmoidal cells, as it is developed from the neural origin, so it is representing a variety of the neural epithelium, which is the olfactory epithelium. Also, we have to put in our mind that as the mucosa of the ethmoidal ear cells has no character, has no the same structure of the mucosa of the other parts of the paranasal sinuses, so the mucosa of the ethmoidal ear cells has no role in the moisturing and lubrication of the sinonasal region. In addition, that the nitric oxide, which is formed by the paranasal sinuses as a general at their cavities, actually this should not exceed the 22 to 29 parts of the gas per billion of parts of the air. And this should be maintained and controlled by the sphincter mechanism that is applied by the natural ostia of the paranasal sinuses. That's why the hyperosteosis, i.e. the extreme dilatation, surgical dilatation of the natural ostia or orifices of the paranasal sinus may interfere with the proper control of the nitric oxide gas at the cavities of the paranasal sinuses as a general. The aim of the nasalization technique, or what is called as extended endoscopic sinus surgery technique, is the complete eradication of the disease and the prevention of the recurrence, as the nasal polyposis is representing with one of the most common characters of it, that is the high rate of the recurrence. The nasalization can be also called, as I mentioned, as the extended endoscopic sinus surgery. What is the nasalization? First, the nasalization was described by rhinologist, sinus surgeon, who's from France, who's the Mr. Roger Jankowski in 1999. This technique was represented by 4 steps: complete ethmoidectomy, complete remove of the lateral wall of the ethmoidal ear cells mucosa, and complete resection of the middle turbinates, in addition to the hyperosteosis. The same surgeon, who is the Jankowski, was modified this technique on 2018, as we will see later, because of the disadvantages of this technique. This technique was found to be disturbing technique to the anatomy of the sinonasal region. It creates the post-operative disturbance of the olfactory function, as well as it is accompanied with the hyperosteosis of the natural ostia of the paranasal sinuses, so it might resulting in the retention of the nitric oxide, and according to the sinus hypoxic nitric oxide hypothesis or theory, this will predispose for the pathogenesis of the migraine. That's why Jankowski tried to modify it on 2018, and the steps was confined to just complete ethmoidectomy, as well as the complete remove of the mucosa of the lateral wall of the ethmoidal earth cells without any intervention with the middle turbinates or the natural ostia of the paranasal sinus. This actually will maintain the contour, the normal anatomical contour of the paranasal sinus or the sinonasal region as a general, and only the disadvantage of this is the prevention of the providing of the sufficient and the proper access for the accessibility of the area to investigate, to look for any recurrence of the nasal polyp and to be instrumentated and interfered accordingly. In addition, that this technique also will limit the ventilation and the drainage of the paranasal sinuses, which already diseased, and resulting in the recurrence of the inflammatory process, which will predispose for the recurrence of the polyps. What's about our technique, Beaufaire's technique? Actually, this was the modification of the previously described two techniques. This was first described in 2021, and the modification which made on the Roger Jankowski technique is that confined to the addition of two, or the we increase the number of the steps of the technique to the 5 steps. We add 2 additional steps, which are the resection of the middle turbinates, but it is not complete resection as the Roger described it on 1885. Just we will resect the lower half or more than the lower half of the middle turbinate, and we add another additional step, which is the partial inferior turbinectomy. As we can see from this video, we can elucidate from this video, this is one of our patients who was operated by Beaufaire's technique. He was a man of age 59 years old, was operated for the nasal polyposis by the functional technique 3 times, and our surgery was the 5th time, the 4th time actually. This video will represent the results after 8 months from the surgery. As we can elucidate here, the cavity is completely free from the polyps. There is no any polyps. All sinuses are patent, including the residual sphenoid cavity, as well as the maxillary antrum. Actually, as we can see here, the mucosa completely is resected. We leave only just a part at the axilla of the middle turbinate, and we perform a partial inferior turbinectomy. The patient was very happy, very satisfied regarding the breathing as well as regarding the olfaction function. There is no any crust formation or atrophic changes can be detected. The mucosa is completely healthy. This is another actually example that demonstrates another patient who is lady of 62 years old. She was operated 4 times by the functional technique, and our surgery was the 5th surgery. As we can elucidate here, there is no any recurrence of the polyp. The cavities are patent. Actually, the patient was suffering because she is completely mouth breather, and she underwent for the inhaler sprays for her recurrent bronchospasm, and now after the surgery was very happy. She leave the inhaler sprays, and actually she feel very comfortable regarding the breathing via her nose, and in addition the olfaction function. Indeed, this technique actually it is very successful technique, and as we can tried from our side to compare our technique with the other 2 techniques, as we can elucidate from our study that we comparing or the parameters that are used for the purpose of the comparison is the healing rate and the scar formation, whether there is any secondary atrophic changes, the rate of the recurrence of the nasal polyposis, the rate of the recurrent attacks of the acute rhinosinusitis, as well as the risk of the migraine. This is actually, our study was presented first on the IFOS, which was in Dubai, actually in 2023. And as we can elucidate from this figure, the risk of the scarring and malhealing was with the conventional Roger-Jankowski technique as compared to the other modified techniques. Also, the recurrence of the nasal polyposis was more with the modified Jankowski technique because of the preservation of many structures, and this will reduce the chance for the proper and sufficient drainage and ventilation to the paranasal sinus. In addition, it limits the accessibility to the cavities of the paranasal sinus to recognize any residual or any recurrent nasal polyposis to be instrumentated accordingly. In addition, we compare the incidence of the post-operative atrophic changes. As we can see, there is no so significant difference, because simply, as I mentioned in my basic concept, is that the ethmoidal air cells mucosa is not responsible for the moisturing and lubrication of the sinonasal region. It is mainly concerned with the olfactory function. As we can see here, as the atrophic changes or the scarring and the crust formations are more with the conventional Roger technique, so the risk of the acute rhinosinusitis will be more with this technique as compared to the other two modified techniques. Regarding the incidence of the migraine, actually by the comparison of the three techniques in relation to the migraine incidence, the incidence among the three techniques actually was 0. This confirmed that the hyperosteosis does not interfere with the process of the control of the nitric oxide as it is claimed. So we can conclude to that the nasal polyposis is a disease of the ethmoidal mucosa, which is functionally, it is olfactory mucosa rather than the mucociliary mucosa as the other parts or as the other sinus regions. Actually, the ethmoidal mucosa has no any significant rule regarding the moisturing as well as the lubrication of the sinonasal cavities. So the resection, the complete resection of the ethmoidal air cells will not resulting into any significant incidence of the atrophic rhinitis, crusting, and the dryness of the sinonasal region. In addition, that the preservation of the middle turbinates will not prevent the atrophic rhinitis also, but it will increase the incidence of the recurrence of the nasal polyposis because of the lack of the proper drainage, lack of the proper ventilation, lack of the good access for the accessibility and instrumentation. So the rate of the recurrence will be higher. The main aim from the preservation in our modified technique, Bufaris technique, the main aim from the preservation of the part of the middle turbinate just to maintain the anatomical contour of the lateral nasal wall. On the other hand, as I mentioned, that the complete preservation may predispose for the recurrence of the nasal polyposis. Complete preservation of the middle turbinate may predispose for the recurrence of the nasal polyposis. This is because of the hidden nasal polyps behind the preserved middle turbinates, that also the preserved middle turbinates, as I mentioned, it will interfere with the proper drainage, proper ventilation, proper accessibility to the nasal cavities or to the middle meatus specifically. The hyperosteosis does not affect the nitric oxide regulation, and as we can elucidate from our study that there was no significant difference in between the three techniques regarding the incidence of the acute rhinosinusitis and the migraine, because simply that the atrophic, that the hyperosteosis does not interfere with the regulation of the nitric oxide, as I mentioned, which is the main cornerstone that playing a role in the incidence or pathogenesis of the migraine according to the sino-nasal hypoxic or sinus hypoxic nitric oxide theory. In addition, that as the atrophic changes are less among the three techniques, because the ethmoidal mucosa has no role in the lubrication as well as in the maintenance of the moisturizing consistency of the paranasal sinus region. So there is no risk for the crust formation, and subsequently the incidence of the acute rhinosinusitis will be less. Finally, our surgery, which is extended non-functioning surgery, as indication should be limited for those patients who are suggested to get a recurrence, or those patients who have the recalcitrant type of the nasal polyposis with high rate of the recurrence. And there are some situations that may consider for the indication of our technique, as the old patients, those who have no tendency to tolerate multiple times to be exposed for the general anesthesia and major surgery like the sinus endoscopic surgery, and those patients who are considered as atopic patients with high risk of the recurrence, also those patients with the Samtur's syndrome or the aspirin exacerbated respiratory disease or syndrome, those patients with cystic fibrosis who developed the secondary ciliary dyskinesia and became predisposed for recurrent attacks of the nasal polyposis, Cartigner syndrome with the primary ciliary dyskinesia with high rate of the recurrence of the nasal polyposis, high immunoglobulin E. It can be considered as a prognostic value for the suggestion of the recurrence of the nasal polyposis with the eosinophilic count. And as these two parameters to be evaluated for every patient, the appearance of these two parameters in high levels indicate the bad prognostic value in relation to the incidence of the recurrence. And at this moment, we can consider in our decision the extended variety of the surgery rather than the functional preservative variety. By the end, I would like to convey my extreme thanks and gratitude actually to the organizing committee as well as the scientific committee of this great scientific event actually. And I hope whether there is any questions in regard, because this is actually very extreme controversy issue and dilemmating, and I suggest and suspect many questions in regard. Thank you very much.
Thank you, Doctor, for your excellent presentation. You can drop your email ID in the chat box. If anyone has any question, they will email you.